Greetings, everybody. I wanted to go ahead and, as promised, um, provide you all with a voiceover on Chapter 39. I think that is the um, only one we didn't do for pharmacology. Chapter 39, dealing with lower gastrointestinal system drugs. We did the upper in class. So let me go ahead and get started so that this is not or too long. Um, let's see, choose which screen. Let's see, window. That's the one I want there. All right, so hopefully this is recording uh, the screen to my left, right? All right, so first things first, let's go ahead and take a look at the learning outcomes or learning objectives. Um, this semester, I've been um, I have been quite intentional, very deliberate in making sure um, I keep these learning outcomes before your eyes, so to speak. It's something that I want you to always keep referring back to as you read through the chapters. Continue to refer back to those learning objectives because oftentimes when students ask me, um, what's going to be on the test, and the only answer I have for you is the learning objectives. If you know the learning objectives, then you know the material. And of course, as I've often told you, I'm not talking about reading, let's say the first objective, and then finding that information in the readings. No, what I mean is you read the objectives, you know what the layout of the chapter looks like, and as you go through each of the concepts, that top down approach, not that spot reading, but that top down approach where you're starting at the top and you're working your way down. That's orderly. And that will allow you to capture everything with respect to that concept instead of jumping over vital information because you're trying to find the objective in the readings. I never heard of something so ridiculous, but nonetheless. All right, so let's take a look at the objectives here quickly. So we want to talk about, or rather, you should be able to describe how inflammatory bowel disease alters function of the lower gastrointestinal system. All right. Number two, list the type of drugs prescribed or recommended for those lower GI disorders. All right. And number three, always consistent, explain the uses, the general drug actions or the mechanism of action, the general adverse reactions or side effects, essentially, contraindications, precautions, and also interactions associated with those lower GI drugs. And then, of course, the pre-admission, ongoing assessment, the appropriate nursing diagnosis relative to these disorders that we'll be discussing, and also ways to examine ways to promote an optimal response to therapy, and especially how to manage common adverse reactions. As you all should know by now, many of these medications have adverse reactions, and though they can be helpful to the patient, we have to make sure we're managing those adverse effects because otherwise they won't take the medication. So, all right. So got that out of the way. All right. Patient. All right. So problems of the lower gastrointestinal system, they include diarrhea, constipation, IBS or irritable bowel syndrome, ulcerative colitis, or UC, and also IBD, or inflammatory bowel disease. As you all can see here, didn't mean to do that. As you guys can see here, um, the this portion here where you see my mouse moving is the small intestine, but that's not for the most part what we are focused on in this particular chapter in terms of lower GI um, systems. Yeah, so that portion of the lower GI system that consists of, for example, the cecum, the ascending because it's going up this way or this direction, and then transverse it goes across, right? That's transverse colon, right? And then descending colon, meaning it's going down, right? This is all going towards the anus, by the way. Then you have the sigmoid colon, which is this portion here, right? And then you have the rectum and then the anus, and that will be our focus here, right? Now, the large intestine is primarily responsible for the absorption of water. Remember, I told you that in class, and also some nutrients from food and fluids that we eat. Of course, most of the nutrient absorption takes place in the small intestine. Now, the speed of transit determines what will be absorbed. So, in other words, the foods food material that we have in our system, the faster it moves, as in diarrhea, then the less is going to be absorbed. So, you want that food material, if you will, to move at an appropriate or a normal pace, so that nutrients, fluids, and so forth will be absorbed. Now, transit of contents rapidly through the bowel, as I mentioned, is referred to as diarrhea. When contents move sluggishly, this means that more water is going to be absorbed, and of course, the fecal material will get harder. And this will result in what we refer to as constipation. All right. So just think, the fecal material is moving very slow, and so that gives the large intestine time enough to pull more and more of that fluid out of that material, and then it becomes a material that is less hydrated, if you will. Now, transit can be this movement of material through the intestine, not the intestine, the colon, different parts of the colon, can be triggered by many things. So, for example, illnesses such as irritable bowel syndrome or ulcerative colitis, bacterial infections, or drugs such as anti-infectives or antibiotics can make transit much faster. And of course, this will result in, again, diarrhea. Now, conditions such as Parkinson's disease, which is like a movement disorder, right, which we'll learn more about later on, can slow the bowel. And of course, because these patients, they have a problem moving normally, and so they're more closer to it being immobile as opposed to mobile. All right, and this causes the bowel to be slower, and of course, more fluids are drawn out of the large bowels or colon, causing constipation in these types of patients. Now, treatment with opioid drugs and treatment with opioid drugs and the after effects, of course, abdominal surgery, any kind of abdominal surgery, can slow down the movement of those fecal materials, if you will, through the colon. And of course, this can result in constipation as well. This is why when these patients are on an opioid, morphine, Dilaudid, Demerol, and so forth, and also with surgery tends to make the bowels, the colon, move much slower. And of course, these patients are more prone to developing constipation. Now, conditions that affect the function of the lower GI system can have a significant impact on ADLs, activities of daily living. If proper absorption does not occur, people may not have the energy to engage in activities. And so the ADLs are impacted, negatively impacted. Now, one such condition that affects function is inflammatory bowel disease. And take a look at figure 31.9 to see what that looks like. Now, another condition, irritable bowel syndrome, also affects the lower GI system. The pain and bloating of a sluggish bowel or fear of stool incontinence. In other words, the people are afraid that they may have an accident and, diarrhea may come about. They might prevent or not socialize with people as often, and this can affect their lives, their normal lives. Now, antidiarrheals, medications that prevent diarrhea, and also laxatives, as well as drugs to treat irritable bowel disease or irritable bowel syndrome, are also presented in this particular chapter as well. All right. So let's take a look at inflammatory bowel disease. All right. Now, according to Crohn's and Colitis Foundation of America, this is a study that was published back in 2021. About 1.6 million Americans have irritable bowel disease. Now, the term irritable bowel disease is used collectively for Crohn's disease and ulcerative colitis. These are diseases that cause inflammation in the intestines, right? So these conditions affect the bowels in the intestines. Now, the cause of these diseases are essentially unknown. But a number of genes, so we go back to genetics, have been identified that are associated with irritable bowel disease. It is thought that genetic susceptibility and also a virus or a bacterial organism that interacts with the body's immune system may be the cause. Right, so it could be a virus, could be a bacteria, and how it interacts with our body's immune system can lead to these conditions. At least that's what they think. And then, of course, genetics might be the culprit as well. Now, signs and symptoms of Crohn's disease include abdominal pain, but also abdominal distension. All right. Now, as the disease progresses, other GI symptoms will be present. And so those signs and symptoms will be anorexia, diarrhea, weight loss because they can't maintain good nutrition. Because of the diarrhea, with some of these conditions, it may lead to dehydration and, of course, nutritional deficiencies. Ulcerative colitis has a more abrupt, a very quick onset. These clients experience a sudden need to defecate, and this can result in severe blood mucus filled diarrhea or no stool at all. So they may not have a bowel movement at all, even though they experience this urge to defecate. All right, or the diarrhea can consist of, it can be bloody and look like mucus is in the stool as well. Now, pain and fatigue accompany this disorder, ulcerative colitis as well. Now, no evidence has been found to support the theory that irritable bowel disease is caused by tension or anxiety or any other psychological factor or disorder. So essentially, these are some of the issues that has been at least thought to contribute to ulcerative colitis, but there's no evidence, so to speak, that implicates um, um, these particular health concerns that contributes to ulcerative colitis. Now, drugs used to treat the irritable bowel disease will be your antibiotics, and so so now we know that there could be an infection that is present. Also, corticosteroids, and of course, we know those medications reduces inflammation. Biologic agents such as your immunotherapy agents to suppress the immune system, and your aminosalicylates as well, which can assist with discomfort or the pain that these patients experience. And we'll be looking at these individually. All right. So take a look at ulcerative colitis, and as you can see, the large bowel is inflamed, right? Starting somewhere around the transverse colon or the last part of it, all of the descending colon down to the sigmoid colon, the anus, and so forth. So it involves everything. And you see how that inflammation here, how it's kind of spotty and whatnot. As far as Crohn's disease also involved the ascending colon, portion of the transverse colon, as well as the descending colon as well. So it's a bit more widespread. Crohn's disease is a bit more widespread. All right, so let's take a look at the aminosalicylates. And what I want you to focus on is where it says salicylates. So when you think about salicylates, that is the generic name for aspirin, right? So this drug has an aspirin-like compound in it. Aminosalicylates, they are aspirin-like compounds, and they have anti-inflammatory actions. Now, you may also hear them called 5-amino salicylate acid or 5-ASA. ASA is actually aspirin. It's like an abbreviation. 5-ASA medications. The drug it has a more topical anti-inflammatory effect in the bowel. All right. Now, the exact mechanism of action of these drugs is not known. The amino salicylates are used to treat Crohn's disease as well as ulcerative colitis, as well as other inflammatory diseases. And so remember, if you go back to your learning outcomes, it talks about the uses of these medications. And so aminosalicylates is used to manage Crohn's disease as well as ulcerative colitis and some of the other ones as well. So that essentially answers that particular objective, if you will. Now, of course, so when you go back to the when you go back to the learning outcomes, it speaks to knowing about the mechanism of action. And as you can see here, the mechanism of action is not known. All right, for this particular medications is not exactly known, but it does seem to have an anti-inflammatory action, right? So I guess what I'm trying to say to you is sometimes, yes, the objective says to know the mechanism of action, excuse me, but some of these medications, scientists, they do not know what the mechanism of action is. All they know is that it works. I know that sounds strange, but that's the way it is in healthcare. Sometimes they just don't know everything. All right. So let's take a look at the most common adverse reactions. And I'm always glad when they say the most common, because that's what you're mostly tested on, the most common. You know, they can list a whole lot of other signs and symptoms, but since these are the most common, you, for the most part, expect to see you being tested on these. All right. Now, because these drugs are topical inflammatory drugs, the most common adverse reactions happens in the GI system, and it's not widespread because it's topical. It's locally in the GI system, and so you have your abdominal pain, nausea, diarrhea. Some of the other general adverse reactions would include headaches, dizziness, fever, as well as weakness. All right. Now, I want you to take a look here. So this is a normal stool here. So as that fecal material is moving through, so the ascending colon, the transverse, and now it's down here to the descending colon, and some water is going back into reabsorbed back into the bloodstream, right? And so this stool will tend to be still hopefully soft. It has enough fluid in the stool. The stool is hydrated enough that it will be easy for this person to have a BM. All right. Now, what happens with diarrhea, as you can see, water from our system is going back. Quite a bit of it. A bit of the water is going back into the bowel or the descending colon, but also electrolytes are going back in there as well. And so when this stool finally moves out of or this person has a bowel movement, it's more liquidy or watery, right? It's diarrhea. And so this is why these patients also suffer not only from a fluid volume deficit, but an electrolyte imbalance as well. As you can see, those main electrolytes, potassium chloride, sodium chloride, if you will. So that kind of gives you an idea of what's happening with the stool as it moves through the colon. All right, so we did this one already, the general adverse reactions for amino salicylates. Uh, let's see. All right. So in terms of the contraindications as well as precautions, aminosalicylates are contraindicated in clients with obviously a known hypersensitivity to the drugs, or if they are allergic to salicylate containing drugs. There are different drugs out there that contains salicylates or aspirin in it, and so they shouldn't take those medications if they have a hypersensitivity to it. Now, in addition, these drugs are contraindicated in patients who have hypersensitivity to sulfonamides and also to sulfites, or if they have an intestinal obstruction. When we talk about an intestinal obstruction, all right, let me kind of go back. All right. So sometimes there is an intestinal obstruction. There may be something like if the colon is very narrow for whatever reason, or maybe there's like a tumor or something within the colon, and it becomes an obstruction. Could be an adhesion from multiple surgeries that has caused scar tissue in this area, and that causes an obstruction. So just think about that. All right, so it'll be contraindicated in those patients with the intestinal obstruction, also in children who are 2 years younger, or 2 years old and younger, or younger than 2 years old. These medications should also be given cautiously in women who are pregnant. This is a Category B drug, except the drug osalazine. This is a pregnancy Category C. All right. And just take a look at my notes. I did highlight that particular one that you should know. So as we graduate higher with these different categories, warning categories, we have to be even more cautious. And also be careful about giving this medication and those who are lactating. In particular, with this one, safety has not yet been established, so just be very cautious. All right, now take a look at the interaction table. You guys should be able to read these by now. So basically, when aminosalicylates are given with digoxin, what ends up happening is there's a reduction in absorption of digoxin, right? Digoxin is commonly given for cardiac problems, especially when the heart muscle is weak. And so if given these medications together, if they reduce the absorption of digoxin, then the heart will not get the medication it needs to operate normally. Methotrexate is used for cancer and autoimmune conditions. And when given with aminosalicylates, there's an increased risk of immunosuppression because these drugs are used to suppress, right? Suppress the immune system. And so there's increased risk of immunosuppression. So these patients are going to, their immune system is really going to be suppressed, weak, and unresponsive to microorganisms, if you will, so they can get sick a whole lot easier. This one, when oral hypoglycemics are given with aminosalicylates, then there's a decreased blood glucose level. So these patients can develop low blood sugars, and they're talking about really low blood sugars. So they may have some issues, if you will, if given with aminosalicylates. All right, so these are the immunomodulators and the biologics. And so these drugs are playing a significant role in the treatment of irritable bowel disease. Now, although these drugs are not aminosalicylates, these biologic agents are being developed for a number of conditions that are caused by issues with immunity. All right. So the immunomodulator include drugs such as the Remicade. This drug works to suppress the body's immune system or reactions. Because remember, when you're talking about these autoimmune disorders where the body is attacking itself, right? We need to modify that immune system in order to prevent it from being so aggressive against itself. So we suppress the immune system, hence the term immunomodulated. We're modulating it, we're changing it, we're trying to control it. All right. So Remicade is one of those. At one time, reserved for those, this drug at one time was reserved for those who did not respond to aminosalicylates or corticosteroids. So those patients who did not respond to either of those medications, immunotherapy is now becoming more prevalent for both induction or when we're starting treatment, rather. That's what they mean by induction. You're starting the treatment. And also remission of inflammatory bowel activity. So we're giving these drugs in the beginning or initiating it, or also AKA induction. And also we're trying to achieve remission of these inflammatory bowel diseases and whatnot. All right. All right, so let's take a look at the antidiarrheals, in particular, the actions and uses. So the antidiarrheals, they are used in the treatment of diarrhea. They work against we're trying to prevent diarrhea. A couple of the medications, Multofen or difenoxin, also difenoxylate or Lamodo. Lamodo is pretty common. Are chemically related to opioid drugs. All right. So remember what happens when someone takes an opioid, like your morphine, Demerol, Dilaudid, and so forth. It slows down the GI system, the intestines, and this is how some patients they develop intestinal ileus, an intestinal ileus, where the intestine is kind of paralyzed, or the it just essentially slows down that peristalsis, right? Because remember, when that transient, when that fecal material is transitioning in the bowels very fast, and it doesn't allow for the body to pull some of that fluid out and back into the bloodstream, then a lot of that fluid remains in the bowels, and that's what makes it liquidy, makes it more diarrhea or loose stools, right? So they give these particular drugs to slow down peristalsis. And if you can slow down, and in essence, when you slow down peristalsis, then that fecal material just moves slower throughout the colon, and more fluids can be pulled out of the colon into the bloodstream, and it makes the stool less watery. Hopefully that makes sense. All right. So again, what you just think about the fact that an increase in peristalsis, that wave-like movement of the intestine, when it's increased, causes diarrhea. But we're trying to slow down the peristalsis. Now, because these drugs are opioid related, they may have a sedative, even a euphoric, make patients feel really good, right? Effect. It may have that kind of effect on these patients, but it does not have an analgesic effect on these tissues. Now, a drug dependence potential also exists, because we are talking about something that's related to opioids. So these patients can become addicted to these drugs, right? So because of that, these drugs are going to be combined with atropine, which is a cholinergic blocking drug. All right. Now, this particular drug, these cholinergic blocking drugs, they can cause a dry mouth and other mild adverse effects. So potential for these patients to abuse these types of medications is reduced because of these unpleasant adverse effects. All right. And that's why they combine them. They're trying to combine them in order to reduce this abusing of these drugs, the potential of abusing these drugs. All right. Now, Imodium acts directly on the muscle wall of the bowel to slow motility, and it's not related to the opioids. So Imodium rather does not have the opioid properties, if you will. It therefore is also used in treating chronic diarrhea associated with irritable bowel disease. Now, the drug crofelemer, this particular drug, it blocks the secretion of chloride, all right, which causes high water volume loss in diarrhea associated with conditions such as AIDS, HIV, and also AIDS. All right, because what happens is whenever chloride is secreted in the bowels, where that fecal material is located, it can actually cause more fluids to be drawn into the large intestine, which will, of course, result in diarrhea. So this crofelemer drug, it blocks the secretion of the chloride, and therefore you do not get all that fluid entering into the bowel, and therefore the stool is less watery, meaning it's more formed, because we're trying to make the stools become more formed. That was kind of a mouthful. Take a look at the gastrointestinal system reactions. You have anorexia, nausea, vomiting, constipation. And think about it. Constipation. So when you think about the fact that these drugs are that their main objective is to either slow down the peristalsis and also to remove or to block, in this case, a chloride and what have you, which will prevent more fluid from entering into the bowel. And so it can lead to constipation. I mean, the patient is experiencing rather diarrhea, and then treatment of these conditions can lead to the other side of it, which is constipation. So you're trying to prevent one thing, and if you're not careful, it can lead to constipation, which is, we don't want constipation. We want them to have normal stools and what have you. And so these patients also have the abdominal pain and discomfort and also abdominal distension. Remember, these drugs are they're more topical. And so you have more signs and symptoms, not signs and symptoms, but side effects happening within the GI system as opposed to throughout the whole body. All right. So these drugs have a more local effect on GI tissue. All right, so antidiarrheals, in terms of adverse reactions, other reactions when you have your dizziness, drowsiness, headache, sedation, euphoria, as well as rash. Remember, some of these drugs have an opioid effect, and so it can cause some sedation as well as euphoria and so forth. In terms of contraindications, now these drugs are contraindicated in patients whose diarrhea is associated with an organism that can harm the intestinal mucosa, such as E. coli, salmonella, and also Shingilla, and whatnot. Now, patients with pseudomembranous colitis, that's the condition that is associated with C. diff. Also, abdominal pain of some unknown origin, or obstructive jaundice, where one of the ductal systems leading from the gallbladder to the GI, to the small intestine, is blocked for whatever reason. And then, of course, the bowel backs up into the liver and causes jaundice. They should not take these anti-diarrheal medications. So, for example, if the diarrhea is associated with some microorganism and you stop the patient from, so basically when you have these microorganisms, the patient is having diarrhea because the body is trying to get rid of those microorganisms. So I give you an anti-diarrhea medication and these microorganisms stay within your system. So that's not a good thing. With respect to your abdominal pain of unknown origin, so you're trying to stop this diarrhea, but we don't know what's going on with this patient. We don't know why they're having the diarrhea. And so we need to really find out before we begin stopping the abdominal pain. In other words, we may mask, what is really actually going on with these patients. All right. Now, antidiarrheal drugs are contraindicated in children younger than 2 years of age as well. Now, when taking over-the-counter antidiarrheal drugs, if the diarrhea continues for greater than 2 days, the patient should discontinue their use and get a hold of the primary care doctor to figure out what's going on. Could be something more serious. Some of the precautions, so the antidiarrheal drugs are used cautiously in those with hepatic impairment. Antidiarrheals are classified as category C drugs for pregnant women and should be used with caution during pregnancy as well as lactation. One of the drugs called loperamide this is an antidiarrheal drug. It is a category B for pregnant women, but it's not recommended for use during pregnancy and lactation, so they shouldn't be ordering that. And although the crofelemer is labeled a pregnancy category C, it has not been studied adequately for pregnancy, lactation, as well as pediatric use. So they should be used with caution as well. All right, let me go ahead and highlight that one too. All right. And here is the interaction table here. When an antihistamine, an opioid, or sedative, hypnotic is given with the antidiarrheas, it can cause an increased risk of CNS depression. So it might depress, for example, respirations. These patients may become more lethargic and unresponsive, and so forth. And of course, the middle part here of this table just shows you why these drugs will be given. So the antihistamine is for allergies, and the opioids would be for the pain, and sedation would be to the sedatives and hypnotics and so forth. All right. And so just take a look at the rest of these. Let's see, MAOI antidepressants given to treat managed depression, and given with antidiarrheals, it can increase the risk of antihypertensive crisis. Increased risk of antihypertensive crisis. So I've never seen it written like that before, but antihypertensive crisis is the treatment of an elevated blood pressure. So hypertensive crisis is elevated, a very elevated blood pressure. And so if there's an increased risk of antihypertensive crisis, it's probably saying that the blood pressure can be lower even the more. All right, that's how I'm interpreting that. It can make the blood pressure decrease quite a bit. All right. All right. So let's take a look at the anti-flatulence. So we're talking about gas or medications to dispel gas from the body, if you will, which can be very uncomfortable. So in terms of actions, the drugs in this category would be your simethicone as well as your charcoal, and they are used as anti-flatulence. And so these are drugs that reduce flatus or gas in the intestinal tract. Now, these drugs do not absorb or remove gas, but rather they act to help the body to release the gas by belching or by passing gas or flatus. Now, simethicone has a defoaming action that disperses and also prevents the formation of gas pockets within the intestine. And charcoal helps bind gas. It binds with the gas for expulsion from the in the way of having a bowel movement, if you will, expulsion. All right, the removal of, if you will. All right, moving on. Your anti-flatulence use and adverse reactions. So here again, we're answering the learning outcomes. The anti-flatulence, they are used to relieve painful symptoms of excess gas in the digestive tract that may be caused by post-op gaseous distension and air swallowing. Some of these conditions can cause gas or air in the GI system, especially after surgery. Also, it could be given or used for dyspepsia, and that is basically fullness or epigastric discomfort. It is given for peptic ulcer disease, irritable bowel disease, or diverticulosis. Diverticulosis is like an out pocket of the colon, right? But without the inflammation. When we say diverticulitis, then that means that those pockets, that tissue that pushes out from the intestine, they are inflamed. But diverticulosis, they're not inflamed. They're just out pockets, if you will. Um, Now, in addition to its use for the relief of intestinal gas, charcoal may also be used in the prevention of non-specific pruritus or itching that is associated with kidney dialysis treatment, and also as an antidote for poisoning. All right. Patients who are on dialysis when because of CKD, all the toxins that builds up in the system and the not the jaundice, but essentially the uremic frost. It can typically cause itching of the skin, and so it appears that charcoal may alleviate some of the itching or pruritus. And also, when patients take an overdose, and whether it be intentional or not, this charcoal helps absorb. We give it by mouth, and it helps absorb the drug in the system itself. Hopefully, giving the patient, making the patient less exposed to the poison. Now, simethicone is in some antacid products, such as Mylanta liquid, and also D-gel liquid. And so I listed those medications that you should add to your list as well. All right. And no adverse reactions have been reported when these drugs are used, which is a good thing. Now, anti-flatulence, of course, are contraindicated with your hypersensitivity. Patients who have known hypersensitivity to any components of that drug, say if it's salicylates or otherwise, it should not be given to those patients. The pregnancy category for simethicone rather has not been established or determined. Because it is not absorbed, it may be safe for use during pregnancy. So, although the primary care doctor should be consulted when any drug is to be taken, just to know what their effects might be. Now, charcoal is a Category C drug, so we certainly want to use that with caution in pregnant women. All right, some of the interactions with this drug, there's decreased effectiveness of other drugs because of absorption by the charcoal. So the charcoal will essentially drink up the drugs that you are giving these patients, other drugs that you're giving them. So it may cause absorption to be decreased, and so patients will not get the full effect of the drug. And also, there's no known interactions with simethicone, all right, because it is not absorbed. Let's see. All right. And now we move on to the laxatives. All right. So in terms of mechanism of action, there are a variety or various types of laxatives. The action of each laxative is somewhat different. So you have to study each one in their own right. They do different things here. But what they all do have in common is that they do relieve constipation. All right, they may just do it in different ways, but they do relieve constipation. Now, the manner of action of the various laxatives are explained in more detail in box 39.1. So I want you to take a look at that. All right. So the bulk producing laxatives are not digested by the body, and therefore it adds bulk and also water to the contents of the intestine. All right. So when these laxatives are taken, the body don't digest it, and they're not absorbed. They just stay in the intestine, and of course it has the ability to pull water into the intestine. All right. Now the added bulk in the intestines, because you're adding more, or the fact that it has this bulk in the intestines, it stimulates peristalsis. So when somebody is constipated, and they take these bulk producing laxatives, it is going to cause those wave-like movements of the stomach. And of course, this moves the products of digestion through the intestine, all right? Because we're making we're initiating, or we are essentially making the intestines move with those wave-like movements or peristalsis even more. And this will, of course, lead to the patient having a bowel movement or evacuation of stool. Now, some of the bulk forming laxatives are your was it psyllium? That's P as in Paul, S as in Sam, YLLIUM. You guys probably know it as Metamucil. Also, Fibercon is another one. Now, sometimes these laxatives are used with severe diarrhea in order to add bulk to watery bowel contents. And of course, this can sometimes slow that transit through the bowel, that movement of fecal material through the bowel. It can sometimes slow it down. Now, the emollient laxatives lubricate the intestinal walls and they soften the stool, thereby enhancing passage of fecal material. Mineral oil is an emollient laxative. You're just lubricating the walls of the intestine, and that makes stools a whole lot easier to move. Now, stool softeners promote water retention in the fecal mass, that feces within the colon. It just those stool softeners allows water to be retained within the feces itself. And of course, this leads to a more softer stool. Now, one difference between emollient laxatives and stool softeners is that the emollient laxatives do not promote water retention, right? Water or retention of water in the stools, right? It just lubricates the walls of the intestine. Now, examples of stool softeners include docusate, colace. Your hyperosmolar drugs dehydrate, or they typically dehydrate local tissues, which cause irritation and also increase peristalsis. And of course, with this, you will have evacuation of fecal material, fecal mass, right? So the hyperosmolar drugs, they stimulate the GI tissue, right? The intestinal tissue, and that irritation will cause more peristalsis or movement, a wave-like movement, and this will cause these patients to have a bowel movement. Glycerin is one example of hyperosmolar drug. All right. Now, irritant and stimulant laxatives, they do tend to increase peristalsis by direct action on the intestine itself. It irritates or stimulates the walls of the intestine, and that's what causes more peristalsis. Remember, the more peristalsis, you're moving that fecal material through the intestines or the colon much faster. And of course, the stools tend to be more softer. Now, an example of an irritant laxative would be like your Senna or Senocot, and also Bisacodyl. All right. Now, also we have your saline laxatives. Saline laxatives attract or pull water into the intestine. So in essence, you're making the fecal material more hypertonic, right? And that hypertonic solution has a pulling effect of that water from our bloodstream into the intestine, right? This would cause an increase in pressure because of that water in the intestine. And of course, that is going to lead to peristalsis, right? And then, of course, these patients will be able to have a bowel movement that is much easier. Milk of magnesia is part of the category of saline laxatives. So as you can see, the different types of laxatives, and they all have different mechanisms of action. So study that well. Some of those are easy to distinguish, like your emollient laxatives, like the mineral oil, and the I think the Senna or Senocot and Bisacodyl is another easier one. as well as a stew softener like your Colace. Those are fairly easy to recognize. Uh-oh. All right. So in terms of laxative uses, the stimulant, emollient, and saline laxatives, prevention of strain during defecation, and so that's what we're trying to prevent straining uh, as one is having a BM, and so these medications would be appropriate for that. Stew softeners or mineral oil, these are given for prevention of strain during defecation, especially after anal rectal surgery or a myocardial infarction. In terms of anal rectal surgery, like hemorrhoid surgery, you don't want someone to be constipated and they have hemorrhoidal surgery because it'd be extremely painful. They're going to hold on to the stool and become more constipated, and so we have greater problems. In terms of myocardial infarction, when patients strain, it stimulates what we call the vagal response or the parasympathetic nervous system. Remember, the parasympathetic nervous system has a slowing effect on the heart. And if that happens, that heart rate may go down or decrease lower than what we want it to the point that sometimes these patients go into cardiac arrest. This Salium and polycarbophil, these drugs are given for irritable bowel syndrome as well as diverticular disease. The hyperosmotic or lactulose agents, remember, these are given to reduce the ammonia levels in the blood, especially those patients who develop hepatic encephalopathy, because the liver cannot clear or convert the ammonia into urea. And so the ammonia levels, they increase. And that ammonia is very toxic to the neurological system. And so these hyperosmotic agents like lactulose it will be able to remove the ammonia or doesn't cause the bacteria that produces ammonia to stay in the system long enough to be absorbed into the bloodstream because it moves it out of the colon very fast. See, when the bacteria is in the colon for too long, it can be the ammonia can be absorbed into the blood, and the kidneys can't convert it to urea, and therefore the number or the ammonia levels will increase significantly, causing those neurological problems. So we give these patients lactulose to try to move those stools through the system a whole lot faster, so their ammonia levels will be lower. That's what we're trying to achieve. In terms of the laxative, or rather, excuse me, the adverse reactions, this can lead to diarrhea. Remember, we're trying to make these patients have a bowel movement. If it is diarrhea, it can lead to water loss as well as electrolytes. Because it is local, these patients can develop abdominal pain, discomfort, and cramps, nausea, vomiting, perianal irritation, especially when the stools are watery. You got that base solution. The diarrhea is more base, and it can irritate the anal area, causing irritation. There's also fainting and weakness, which could possibly come from the nausea, vomiting, the electrolyte imbalance, and so forth. These patients also might feel bloating as well as flatulence. Let's see, allergic reaction, this tartrazine containing laxatives, these patients can develop an allergic reaction to these drugs, the tartrazine containing laxatives. So be careful with that one. Obstruction of esophagus, stomach, small intestine, or colon it can rather cause an obstruction with the bulk forming laxatives, and so be careful giving the bulk forming laxatives because it can lead to these GI obstructions. All right. Another thing I need you guys to keep in mind is that prolonged use of laxatives can result in serious electrolyte imbalances, as well as laxative habit. That is when patients become dependent on laxatives to have a bowel movement, especially the older population. They tend to become a habit forming for them. Now, some of these products, again, they do contain this tartrazine, which is a yellow food dye, which may cause an allergic reaction in these patients, especially if you have like bronchial asthma. And when you have an allergic reaction, and with the fact that you have possibly bronchial asthma, it can cause your airway to close off even more. All right. Now, where I talked about the obstruction that can occur with the esophagus, the stomach, small intestine, and the colon, uh, that it occurs with the bulk forming laxatives. Um, these are administered without adequate, when they're not rather given with adequate fluid intake, then it can cause these obstructions. And so these patients have to drink enough fluid when they're taking the bulk forming laxatives. Um, Also, these obstructions can occur if a patient has intestinal stenosis. So the intestine may be due to many surgeries where scar tissue or adhesions may have developed and causes the intestine to be more stenosed and more narrow. All right. Now, in box 39.2, these are some of the drugs that can lead to constipation. Your anticholinergic drugs or cholinergic blocking drugs, which is the same thing. Your antihistamines, your phenothiazines, tricyclic antidepressants, opioids, non-potassium sparing diuretics, iron preparations, barium, colonidine, as well as acid containing or antacid containing calcium or, excuse me, aluminum. All right. So if any of those drugs are to be given, you need to be aware that they can lead to constipation. Contraindication with laxatives, hypersensitivity to the drug. If someone has persistent abdominal pain, it would be contraindicated to give these medications. If they have nausea, vomiting of unknown cause, we need to figure out what it is first, instead of continuing to give this medication. Also contraindicated with patients who have signs of acute appendicitis, fecal impaction. If they have a fecal impaction, the laxatives probably won't do very much with that. Also, if they have an intestinal obstruction, you may cause the stools to be more softer, but because of an obstruction, it's still not going anywhere, especially if the obstruction is very severe. And also those patients with acute hepatitis, it would be contraindicated to give these medications. We have to use these medications cautiously in patients with renal impairment. Some of these laxatives have magnesium in it, and if someone has renal impairment and they're not able to remove the magnesium from their system in the urine, then it can build up to dangerous levels. Rectal bleeding, use with caution with rectal bleeding, pregnancy, category C, and also lactation. Now, again, just pay attention to the fact, especially the older population who are taking a lot of laxatives to have a bowel movement. It can lead to a lot of problems, um, especially dependency. All right, take a look at this is really important here. Take a look at this interaction table. So we have these vitamins that we refer to as fat soluble vitamins, and that is ADEC. I call it ADEC. It's A, D, E, and K. When these drugs are given with mineral oil, the body of the GI system does not absorb them very well because they're fat soluble, right? And so when given with the mineral oil, as you can see here, impaired absorption of the fat soluble vitamins. Again, that's when they're given with mineral oil. The mineral oil prevents their absorption in the GI system. Any other drug with laxatives, use specific to each drug, of course, causes reduced absorption of other drugs by combining them chemically and hastening their passage through the GI tract. So they'll come out in the bowels very quickly when given with some of these drugs. Surfactants with mineral oil, they usually use these to treat constipation. And of course, if so, it can increase mineral oil absorption. So these patients will get more of the mineral oil than they actually want or need. All right. In terms of, so these are some of your interactions with the laxatives. Milk antacids, H2 antagonists, and also PPIs or proton pump inhibitors. Bisacodyl tablets should not be administered within 1 to 2 hours of bisacodyl tablets or enteric coating, which may dissolve early, resulting in gastric lining irritation or dyspepsia or gas, and decreasing the laxative effect of the drug. So be careful about when these drugs are administered and make sure they're spaced out accordingly. Um, all right. See, let me, so milk antacids, histamine, H2 antagonists, the acid um, reduction. Proton pump inhibitors should not be given 1 to 2 hours before bisacodyl tablets because the enteric coating, which is the bisacodyl tablets, they usually coat it, right? The enteric meaning intestine, coating may dissolve early. That's why you don't give this bisacodyl with these particular drugs because it can cause the coating to dissolve on the medication to dissolve too early before it can actually reach the intestine. See, the reason they coat some of these drugs, like the extended release drugs and so forth, is because we want the drug to be able to reach the small intestine and not be destroyed before that time. As long as it has the coating on it, it protects it from the GI secretions like the hydrochloric acid and so forth, allowing it to reach the intestine and to be absorbed, of course. If the coating is absorbed or dissolved too soon, it can result in gastric lining irritation or dyspepsia, or it can also decrease the laxative effect of the drug as well. So, given these drugs with the enteric coating type of drugs like bisacodyl, it's not recommended, if you will. So make sure you're giving these other drugs here listed 1 to 2 hours before, so the drug can have its full effect, if you will. All right. Now, as far as weight management, you guys have probably heard of some of this. Some of the one of the drugs that is used for weight loss is your orlistat. It makes fat indigestible, so these patients are not able to digest fat. That's what this drug does. It causes it to pass through the intestine without being absorbed due to inhibiting lipase. So in other words, if you prevent lipase, which is produced in the pancreas, from being produced, then it cannot break down the fat in the intestine, and therefore you will excrete it in the stool, not absorbing the fat. They use it for weight loss and also weight management. Some of the adverse reactions: loose stool, causes increased flatus. That's a big one. Fecal urgency, and also incontinence with fatty or oily stools. That fatty or oily stools is the fat that is not digested. These medications are contraindicated in your patients with gallstones. All right. They typically give these drugs for obesity management. These patients have to have a body mass index of over 30. All right. The drug works by inhibiting lipase, which is an enzyme that breaks down fatty or dietary fat. As a result, the fat eaten is indigestible. You can't digest it, and it passes through the intestine without being absorbed. And although this drug is not a laxative, the action of the drug results in loose stools and increased flatus and so forth. So make sure you take a look at the rest of this. All right, and then of course we have the pre-admission stuff here, which I'm going to stop right here and just make sure you guys read the pre-admission information. It's basically what we've talked about, or what I've talked about here already, but we are putting it or integrating these medications into the nursing process itself. All right. Uh, Sometimes I get a little tempted to do it anyway, but let me know if you guys are having any problems, going through the nursing process and applying it to the medications. All right, I think that's about it. All right, folks, I appreciate your attention to this, and hopefully I have made this clear enough for you guys to understand. So let me go ahead and stop sharing, and I will get this out to you all as soon as possible. Thank you.